Hello, everyone, and welcome to another episode of the Science and Chill podcast. I'm your host, Brady Holmer. My guest on this episode is Dr. Brad Stanfield. Dr. Stanfield is a medical doctor trained in New Zealand who has a particular interest in optimizing health span and lifespan through the use of nutritional and lifestyle interventions. Dr. Stanfield is also quite the expert in supplements with the potential to enhance health span and lifespan. And as you will hear in our conversation today, he approaches supplementation in an incredibly evidence-based way that I really admire and think that you will find great utility in. In this episode, we talk about what healthy aging and lifespan are, the best ways to promote health span and delay aging, the supplements that Dr. Stanfield recommends or is very excited about, some of supplements that he has currently stopped taking and the various reasons why. And this is a very interesting part of our conversation, as he has stopped taking many of his supplements due to recent evidence and changed his mind, which I find admirable. We also talk about some of the recent controversies in longevity research, which Dr. Stanfield has played a role in bringing to the public eye, along with my previous guest, Dr. Charles Brenner. I encourage you to check out that episode as well after you listen to this one to get more context in terms of what is going on in the longevity research area and some of the controversies around aging science. I first became aware of Dr. Stanfield after stumbling upon his awesome YouTube channel, where he does a lot of comprehensive breakdowns on aging research and supplements. I really encourage you to give him a follow on YouTube and other social media platforms because he is producing really great content. If you enjoy this podcast and would like to support it, there are several ways to do so. The first way is by becoming a supporter on Patreon. With Patreon, you can support the podcast with a monthly donation at any level you'd like. And you can start showing your support right now by going to patreon.com/Brady Holmer or checking the show notes for a link to my Patreon page. You can also make a one-time donation to help support the podcast through PayPal or Venmo, or if you so desire, Bitcoin or Ethereum. These options can all be found on my website by going to bradyholmer.com/donate. There's also a link in the show notes to the support page where all those options are available. Thanks so much to anybody who supports this podcast on any level. It makes a huge difference. And finally, checking out the podcast sponsors is also a fantastic way to show your support. There are two sponsors for today's podcast, both of which are products I use frequently and absolutely love. The first is Element Electrolyte Drink Mix. What is Element? It's a sugar-free, carbohydrate-free, and tasty drink mix that contains scientifically formulated amounts of sodium, potassium, and magnesium. And Element comes in single-serve packets, which are great to add to water for any time around your workout or just to sip on throughout the day. I'm routinely using about 2 to 3 of these each day, usually one before, maybe during my workout, and then one in water throughout the day just to get some extra electrolytes. I really have found that taking electrolytes improves my mental and my physical performance. Plus, it just tastes great. Element comes in a variety of flavors, including one of my favorites, citrus salt, along with raspberry and watermelon. They also have some spicy flavors, which are pretty interesting. And you can try a free 8-pack sampler of Element if you go to drinkelement.com/science-and-chill. And you can also check a link in the show notes for this special offer for my audience. I've also partnered with Health via Modern Nutrition, or HVMN, to bring a special offer for my listeners on their brand new Ketone IQ drink. Ketones are sometimes referred to as the fourth fuel, and they can be used by our muscles, heart, and brain for energy, just like carbohydrates or fat. With exogenous ketone drinks like Ketone IQ, you can rapidly elevate your blood ketones and put your body into a state of exogenous ketosis, similar to what would happen on an extended fast or if you were eating a ketogenic diet, but it happens much quicker. And studies have found, and I have also experienced, that taking ketones can help with mental performance and clarity, athletic performance, and maintaining energy levels throughout the day, especially if you're experimenting with something like intermittent fasting or time-restricted feeding. If you've not yet tried ketones, I really encourage you to give Ketone IQ a try. You can get 10% off your order of Ketone IQ by going to HVMN's website, using the link in the show notes, and entering code Brady10 at checkout. Again, use the link in the show notes, Purchase some HVMN IQ, enter Brady10 at checkout, and you can get 10% off your order of Ketone IQ. And last but not least, if you enjoy my podcast, then you'll probably also enjoy some of the writing that I publish on a weekly basis, including my weekly newsletter that I send out every Friday called Physiology Friday. And if you'd like to check out my writing and subscribe to my Substack to receive weekly posts, please visit bradyholmer.com/Substack. You can also find a link in the show notes. And actually, correction to that link, it's bradyholmer.substack.com. But if you check the link in the show notes, it will take you right to my Substack. As always, thanks for listening, and please enjoy my conversation with Dr. Brad Stanfield. Dr. Stanfield, welcome to the Science and Chill podcast. I'm so glad we could link up.
Yeah, thanks very much. Looking forward to our chat.
No problem. So before we get started and dive into some of the topics that we have on the list today, could you please provide listeners with a brief background about yourself, currently, where you're located, some of your medical training and maybe academic history, and then how you got interested in health and longevity and where you're currently working now?
Yeah, sure. So I'm a medical doctor in New Zealand, and I finished my medical training in 2015. So I've been a doctor for 7 years now. And I currently work in general practice, so family medicine. And I quite like that because you can actually get stuck into the weeds, if you like, about patients' health, and you can see their health journey from start to finish, if you like. And that's quite a difference from where I first started medicine, which is working in the hospital, because ideally a patient comes in, you patch them up, and then you send them on their way again. So it's quite nice to develop that relationship over a longer period of time. And I got interested in health and well-being and longevity, if you like, from quite a young age. I was always into sport, so I always wanted to find out, is there some way that I can actually improve my performance? So, taking things like creatine and omega-3. But then as I started to get into medical school, I noticed that I started to get some wrinkles around my eyes. And that got me thinking, what can I actually do now to stop the aging process? And then I came on to Dr. David Sinclair's podcast on, he was actually on the Joe Rogan podcast. And that got me interested, thinking, that there were a lot of these molecules and interventions that were almost about to come mainstream, that I wanted to start to talk about. So yeah, and I also realized that online, there's so many different people talking about, health and supplements and whatnot. And a lot of what they're doing is extrapolating cell or mice data. They're not really focusing in on what the human clinical evidence actually shows, and that can lead you down some potentially dangerous paths. So I wanted to create a resource where people could actually have a look at these supplements, but through the lens of human clinical evidence. So that's
and for sure. No, thanks for that background. And you really do have an awesome YouTube channel, and that's actually where I kind of discovered a lot about you and started learning about the work that you're doing surrounding supplements. I love just kind of binging. I went on a binge one night and just started binging all of your videos on YouTube about the different supplements and things. It's all super fascinating. And I definitely appreciate that work because, as you said, a lot of what's being talked about right now, a lot of just the evidence is only in sort of animal studies, and hopefully, that will change as people become more interested in these supplements for health span and lifespan. But yeah, I think it's definitely important, especially when we get into discussing things today, to differentiate between this work has been done in animals or this work has been done in humans. So, right now, a lot of it is sort of just self-experimentation, which I know you're doing a lot of, and seems like kind of what got you interested in the supplement space, seeing whether these supplements could actually help you with your own health span and lifespan, and perhaps reducing some wrinkles. So before we get into supplements, that's kind of going to be a majority of our discussion today, but I'd like to maybe just set the stage and talk about, we talk about aging and health span and lifespan, kind of all of these different terms, but could you maybe just describe from your perspective sort of what is aging, maybe some of the reasons why you think that we age? I know there are several theories as to why people think that we age, and then maybe talk about health span versus lifespan and differentiate those two terms.
Yeah, I actually think I think we'll start there, if that's all right. So with lifespan, that's exactly it. How many years will we have on planet Earth? Health span to me is actually a bit more interesting because it says how many of those years, or what proportion of those years, will you be healthy? Will you be able to do the activities that you want to do? and essentially free of disease. And that's quite interesting, because in clinical medicine, that is what we're striving for. We're striving to prevent disease from happening in the first place. It's far easier to prevent, diabetes and heart attacks and strokes, as opposed to treating those. So I think that's quite important, that focus on health span, and that's what I try and do on my channel. But in terms of why we age, and why we've got this theoretical, 115 or 120 year maximum lifespan, there's theories, but I don't necessarily think anyone's got a true understanding about why that happens. So, in 2013, there was a landmark paper published titled The Hallmarks of Aging, where there were 9 hallmarks of aging that were mentioned. And one of those hallmarks that I'm particularly interested in at the moment is deregulated nutrient sensing. So there's the enzyme that I'm particularly interested in is called mTOR. So you may have heard, gym junkies talking about mTOR. They want to activate mTOR because it builds muscle. But it seems that as we age, our muscle mass declines. But with that decline, there's this increase in mTOR, which is, it's almost like the body is trying to compensate for this lower level of muscle to try and rebuild that muscle back. But the problem is, with mTOR being switched on all the time, then you're not activating another process called autophagy, which is the cell clearance process. So it looks like as we age, we're building up all of these old cell components. So, old and damaged mitochondria, for example. So I'm particularly interested in a molecule at the moment called rapamycin, which is a molecule that actually blocks mTOR. So it switches it off, and that allows that cell clearance process to happen. But then equally, you also want periods of time where you're still switching mTOR on. So it looks like if you use rapamycin intermittently, you can help with this deregulated nutrient sensing hallmark of aging. So yeah, that's what I've designed a clinical trial around, and that's what we're fundraising for at the moment. But at the end of the day, I don't necessarily think we have a firm grasp as to why we age, but we do know that there are some things that we can do to modify that aging process.
Certainly. And I think that there are all these hallmarks of aging, and aging is probably just a composite of all of those hallmarks. It's not just oxidative stress or just deregulated nutrient sensing or mitochondrial dysfunction or inflammation. I'm not quite sure what all of the hallmarks are. I have read that paper though, and it is very interesting. But yeah, regarding the nutrient sensing, I hadn't actually heard that mTOR was sort of increased with aging in terms of maybe constantly being switched on. So are you saying that is sort of a compensatory response? Maybe, I know muscle mass and things like that start to decline with age, but the body's sort of trying to fight those declines, or is it trying to rebuild different structures, and that's why mTOR is constantly activated?
I don't think we know. I don't think we know. When it comes to, deregulated nutrient sensing, so mTOR is one of the quite upstream nutrient sensing enzymes, but there are other nutrient sensing enzymes that seem to have the same effect, where they're either over or under expressed with aging. And I don't necessarily think we know why that is. And that comes back to, I don't think we've got a firm grasp as to why we age. But from the interventions testing program, which I'm sure we'll talk about soon, they use specific molecules, and they can see that those actually change the aging process. And one of them is rapamycin. So yes, we don't have a firm grasp as to why we age, but it looks like we can influence that process.
Yeah, and by studying these different drugs, if we figure out that some of them work, I think that we can get a little bit closer to defining why we age and sort of seeing what the upstream processes that are causing the aging process are. With your patients, and maybe even with yourself, I'd be willing to talk about it as well. What are you kind of more concerned about? I know a lot of people, they want to live a healthy life. They want to have a high quality of life until sort of the end. It's like this, the concept that I guess they call compressed morbidity, basically living high quality life, high energy towards the very end, where it's just the last few days, then you're gone. But when you're designing interventions and consulting with patients and things like that, what are you more concerned about? Maybe optimizing health span or lifespan, or do you sort of think about both when you're prescribing interventions or even using interventions for yourself?
Yeah, it's kind of both. So, I mean, the classic one that I often see patients for is high blood pressure. So with high blood pressure, ideally we want their systolic blood pressure below 130. And there's many different reasons as to why their blood pressure is up in the first place. But if their blood pressure is high, then that does increase the chance of heart attacks and strokes. And again, prevention is always better than treatment. So we try and optimize their blood pressure to prevent those things from happening. So, diet and exercise always comes first. So, for some people, they might be drinking too much alcohol or having too much salt in their diet or not exercising enough. And those are the reasons for why their blood pressure is high. So we work on those lifestyle factors. But if that's not enough, then we add in medications to help that process and to lower their blood pressure. So, and it's a similar thing for diabetes as well. But so all of that is kind of around prevention, and preventing disease will help both that patient's health span and lifespan. So I don't dissect I don't think, oh, this intervention is going to help with lifespan and this intervention is going to help with health span. It's all in the same. It's sitting in front of with my patient, making a management plan for them that will work with their lifestyle to improve their health and keep them healthy for as long as possible.
Yeah, I think that's a great point to make. And I almost think about it in the same way, in that they almost really can't be decoupled from one another. I mean, anything you do to increase health span, to increase quality of life, I mean, will in some way probably contribute to lifespan, because if you think about why people eventually die, it's from some disease. I mean, most people aren't just dying of, say, old age, I mean, it's always something like you're dying from complications from diabetes or cardiovascular disease or a stroke. So it's like, if you can prevent those or delay cardiovascular disease, you are, in a sense, optimizing longevity. I often think, though, where maybe the conversation on optimizing one and sacrificing the other comes in is like, there are certain interventions that, may not have even been proven to date, but maybe something like, I'll just say, like calorie restriction. So, a lot of people will say, these people who practice calorie restriction, dramatically reducing how much they're eating, they're doing that simply to optimize their lifespan. And maybe that comes at sacrificing quality of life. For instance, if you're low energy all the time and you're constantly suppressing your mTOR and like your muscle mass is just incredibly low. So that might only be like one case of where sacrificing health span for lifespan. But, do you know of, I guess, would you agree with that? Most of the time they're probably tied together.
Yeah, it's tricky. There's a couple of examples that I think we should talk about. So let's start with calorie restriction.
Sure.
So calorie restriction, when you're younger, probably helps your health. It probably extends your health span, probably. But I get really concerned when older people are trying to do calorie restriction. So, older people, they are losing muscle mass. And if I'm trying to tell these older people to lose or to reduce their calorie intake, you look at them and they become thinner and thinner and become more and more frail. And that frailty then increases their chances of, infections, and it actually increases chance of heart disease and everything like that. So calorie restriction, it's not just a blanket rule that everyone should be calorie restricting. So for certain people, yes, it may improve things, but for other people, it may actually make everything worse. It may make both health span and lifespan worse. So it's trying to come up with interventions for that specific patient sitting in front of me. The other intervention that's often talked about in terms of health span and lifespan is things like testosterone replacement in older men. So there are some people that have got true low levels of testosterone and they're getting symptoms from that. And in those instances, then yes, it makes sense to replace that testosterone. But it's actually a very, very, very small proportion of men that would actually benefit from testosterone replacement therapy. Most men, when they are replacing testosterone, they're actually making their health span and lifespan worse. So most of the time, older men have got enough testosterone so that when they are working out at the gym, they will get muscle performance benefits. Yes, there's this very small proportion of men who don't have enough testosterone that need that extra top up so that they can get those benefits from exercise. But most men, over 90% of men don't need testosterone replacement therapy. And the risks with testosterone replacement therapy is that it does lead to heart attacks and it does lead to increased rates of prostate cancer. So yeah, I just want to make that distinction that, again, for some men, testosterone replacement therapy works and it will extend both their health span and lifespan. But for the vast majority of men, it will make both things worse.
So in the case of where it would benefit for extending health span and lifespan, it would only be in those men who were deficient, you would say?
Deficient with symptoms. So,
right.
Yeah, so it's almost like if you listen to things like the Joe Rogan podcast, the impression that I get is I'm not convinced that they are aware of the large-scale trials that have been done with testosterone replacement therapy. There's been massive trials looking into this in older adults, and there's a reason why most medical practitioners don't just willy-nilly prescribe testosterone replacement therapy to older men. It's because the lifespan and health span effects actually are worsened. It's just that small proportion of men that are both deficient and who have got symptoms that will probably benefit from testosterone replacement therapy. But the vast majority of men, it makes things worse.
Okay, no, that's very interesting and good to know, because again, yeah, you did mention on, how, say, Joe Rogan, and I'm sure any other podcast, but it seems like the conversation generally is like, oh, we're just assuming that all older men are like deficient in testosterone. That's kind of the impression that I get. And again, I'm not a medical doctor and not really aware of the literature on, levels of testosterone and reference ranges and things like that. But I would get the impression just from, we'll just mention him again, because that's kind of quite where somebody will come on his podcast and be like, yeah, you need to be on TRT because you're over 55 or something like that. So it's interesting to know those kind of data that I was unaware of.
Yeah. There's other things that people can do if they wanted to boost their testosterone. Simply working out will increase your testosterone and will help to prevent that testosterone decline with age. And it comes back to, you can't beat diet and exercise. Diet, exercise, and sleep, they're a pretty powerful trifecta to improve both health span and lifespan. So when it comes to adding things to your body, such as supplements or testosterone in this case, just be very aware that oftentimes there's very good data out there showing why we shouldn't be using X, Y, or Z, and we should just be focusing on diet, exercise, and sleep.
Absolutely. And I think, that examples, you can think of many other examples, maybe even too, with things like Metformin and so on, where, we have this supposed benefit and maybe this could be beneficial. And then when you actually look at it, say in healthy people who are taking it, it might not be as beneficial as we think. But we can perhaps touch upon Metformin a little bit later. Just one more thing maybe about, health span and lifespan before we move on. What's your opinion on our ability to significantly extend lifespan in humans? So obviously, I think we have good evidence that there are lots of interventions that you just even mentioned, diet, lifestyle, things like that can significantly improve health span. But what's your opinion on extending lifespan significantly? Do you think we currently have the means or the technologies to do that? Or do you see a time in the future when we might? And if so, what kind of might those interventions be? Because I'm not totally convinced that just with diet, maybe in lifestyle, we can really significantly extend human lifespan. And by that, I sort of mean like, maybe increase it up to, say 140, 150 years for kind of the known maybe max lifespan for humans.
Yeah, so I think it depends on what lifestyle metric we actually want to talk about. So are we talking about extending the maximum theoretical lifespan, as in the 115 to 120 year limit, or the average human lifespan?
I would say the maximum theoretical lifespan in that case. Yeah. So not the average lifespan.
Yeah, because I think we probably can increase the average lifespan, but I think Absolutely. It is quite interesting to talk about the maximum lifespan. The interventions testing program is probably the best program that shows that we probably can extend maximum lifespan. So I think let's just dive into the interventions testing program briefly, because I think that's quite a crucial area of research at the moment. So
yeah, great. We've mentioned that a couple of times. So why don't we go ahead and talk about what that is?
So the interventions testing program, it's remarkable because of the type of mice that it uses and the breadth of research. So most mice research, they're using inbred strains of mice. Whereas the interventions testing program, they're using genetically diverse mice. So it more matches the human population because, we are not inbred. And the interventions testing program can do this because they're using so many mice in each experiment. And one of the big problems with science today is this idea of reproducibility, that if one lab comes up with a result, often it's quite difficult for another lab to come up with that same result. So the interventions testing program, they run the exact same experiment in 3 separate labs at the same time to see, are they seeing a true result, or is it just a quirk of one of these labs? So yeah, so because it's run in genetically diverse mice in 3 separate labs, with the amount of mice that they're using, any result that comes from that program is you need to take note of it. And there are certain interventions that they have found that does extend maximum lifespan. So that's in mice. Will that correlate to humans? I'm not sure. And further trials need to be done. But I think that does show that in certain mammals, we can extend maximum lifespan. So possibly we could do that in humans, but again, it's difficult to do a trial like that. But I think there's the possibility that we could.
Yeah, certainly. And I do think that's an important thing to differentiate as well. You mentioned, talking about actually extending maximum lifespan, because a lot of the studies that have been done, when they say, oh, this X intervention increases lifespan, it's often like the average lifespan of the animal. And so it's a bit deceiving sort of when they talk about that in a lot of studies, and a lot of people that, that might not be something that they understand. In the interventions testing program, we just brought that up. And so I would love to sort of now dive into maybe certain supplements for, Healthspan. And maybe a great place to start would just be what supplements you're currently using. I know that on your website, you have a very detailed list of sort of your supplement and your exercise stack, which is very interesting. So why don't we get into what supplements that you're currently taking to support your health span, to support energy, performance, and things like that. And then maybe for some of them, if there are any in particular that you find primarily interesting or would like to talk about, we can maybe go into a little bit more detail on those.
Yeah, absolutely. So I think let's start with the supplements that I'm taking because of the results from the interventions testing program. So the interventions testing program back in so this was a paper published in 2016. It was looking at a molecule, a combination of molecules, and the brand was called Protandim. This was a blend of molecules that activates an enzyme called NRF2. So NRF2, it's the so-called master antioxidant switch in the body. And when the mice were supplemented with Protandim, so this NRF2 activator, it extended the male mice lifespan by 7%, so, which is interesting because people often talk about, antioxidants, and there was a thought back in the 90s and early 2000s that we wanted to boost our antioxidants as much as possible, that oxidants were terrible and they were causing all sorts of damage. But actually, that doesn't necessarily seem to be the case. It seems that we want to strike this perfect balance between oxidants and antioxidants, because it looks like when used in the correct way, oxidants, they do switch on pro-survival signals in the body. So when it comes to my supplement stack, I think I do want to activate NRF2 on days that I don't exercise, because when you exercise, you release all sorts of oxidants, which are good, because you want to signal to your body that it needs to become more efficient. So I take sulforaphane, which is one of the most potent activators of NRF2 that we know of, on days that I don't exercise. And again, that's because of the interventions testing program data. So that's kind of the first one. The second one that I plan to start taking when I reach the age of about 45 years old is glycine. So glycine is one of the building blocks of a powerful antioxidant called glutathione. And when glycine was trialed by the interventions testing program, it extended lifespan, I think from memory, it was about 8%. No, sorry, 4 to 6%, but they were using a very high dose of glycine. So when it comes to humans, it looks like our glutathione levels, they're actually okay until the age of about 45. And then the oxidants overtake, our glutathione processes. And then there's this massive drop of glutathione. So it looks like if we support our glutathione levels by using glycine and possibly NAC, then maybe we can prevent that balance from getting out of kilter. So that's kind of the second one. There's a couple of other molecules from the interventions testing program that I'm interested in, but I'm not currently taking. So one of them is rapamycin, which we've talked about. In humans, rapamycin is used to help prevent organ rejection. So if you need a kidney transplant, one of the drugs that you'll probably be on to stop your body from rejecting that organ is rapamycin. So it's got a bit of a dirty name in clinical medicine. And there's not enough human data yet on rapamycin when you give it to healthy individuals. And that's one of the reasons why I've created and started my own rapamycin clinical trial, so that we do have that data to see if it's a good idea to take in humans or not. So until there's more human data, I'm not taking rapamycin, but again, I'm very interested in it. And that's why I've done the clinical trial. It's a similar story with another molecule called 17-alpha estradiol. So this is the so-called non-feminizing estrogen. And when the interventions testing program trialed this, it extended male lifespan by 19%, which is basically just as much as rapamycin. And that's a very interesting finding. It sounds baffling that if you gave estrogen to males, that it would extend their lifespan. But if you walk it back a bit, you know, virtually every single population of in humans, females, they've got a longer lifespan than males. So it's possible that estrogen's got something to do with that. And if we can use a non-feminizing estrogen to help bridge that gap between males and females, that's quite interesting. Again, we don't have enough human data yet for me to take that or to recommend that anyone else takes it. And future trials need to be done, but that's a very interesting molecule.
Yeah, there are actually a lot of cardioprotective effects of estrogen, actually. So I could definitely see how, you know, in males, even maybe supplementing with that could potentially be beneficial, again, if it was the non-feminizing versions of estrogen. But yeah, there's lots of cardioprotective, lots of benefits on endothelial function and cardiovascular health that have been shown with estrogen or for estrogen.
Yeah, absolutely. And that's one of the big reasons why. So in postmenopausal women, you know, not testosterone, hormone replacement therapy, it was kind of the next big thing. And then some data came out suggesting that it increased, you know, breast cancer and whatnot, and then medicine switched off from it. But now it looks like it's actually safe to give in women between the ages of 50 to 60. So that's the current guidelines that I follow. So in a lot of the postmenopausal women that I see who have got symptoms, we're using estrogen to help with their symptoms, but we can see that it also improves their cardiovascular risk profile as well. So yeah, estrogen is a very interesting molecule. In terms of, yeah, do you want me to talk about other molecules that I'm taking as well?
Yeah, why don't we can continue to talk about a few for sure. Yeah.
Yeah. So speaking of wrinkles, because that's what I sort of first brought up at the beginning of this. So when I first looked at collagen, because I was hearing a lot of social media hype about it, I thought it was complete rubbish. But then you have a look into the data and it's actually quite interesting. There are randomized placebo-controlled studies that do show that if you take collagen, it seems to improve skin health, that it does reduce wrinkles. And if it's improving wrinkles, you know, there is the possibility that it's improving other soft tissue structures, such as blood vessels and your organs and things. So I take collagen 10 grams every day, and I mix that in with either my coffee or smoothie. And it's a similar story with things like hyaluronic acid. Again, when I first looked at hyaluronic acid, I thought it was garbage, because how could the body absorb such a large molecule? But for whatever reason, in these double-blind placebo-controlled studies, it seems to improve skin health again. And if it's improving skin health, is it helping joints? Is it helping your blood vessels as well? We don't have the data yet, but it seems quite clear that it does improve skin health. So, you know, that's another molecule that I take. And hyaluronic acid, it might also be one of the key reasons why the naked mole rat has such a long life compared to other similar species. There was an interesting paper looking at apigenin. So there's been a lot of hype in the so-called longevity space or health span space about NAD precursors. So this is, NMN, nicotinamide, riboside, and niacin. So when the interventions testing program trialed nicotinamide riboside, there was no lifespan extension seen, which I think is an interesting point. Now, if you speak to experts in this field, such as Dr. Charles Brenner, he will talk about if you take nicotinamide riboside, what you're doing is you're helping your metabolism weather these attacks. So attacks from sunlight or alcohol or, lack of sleep, things like that. So that's possibly where nicotinamide riboside will have a role. But one of the reasons, one of the proposed reasons as to why NAD levels go down, which is why we're taking nicotinamide riboside and things anyway, is this enzyme called CD38. So there was a paper that was just recently published using a CD38 inhibitor that extended mice lifespan fairly significantly. Now, that paper, it was in inbred mice, so that's quite key, and it was using a small number of mice. So we need to interpret those results with caution. But I think it's interesting that possibly by using a CD38 inhibitor, we might see health span benefits. So I take apigenin, 250 milligrams every day to help to prevent that CD38 increase with age. And again, it's interesting. We don't have much human data on it, but I take that because I find the mice data intriguing. I'm curious to hear your thoughts around CD38 and NAD, because I believe you've interviewed Dr. Charles Brenner as well.
Yeah, actually, he was on my last episode of my podcast. I interviewed Dr. Brenner, and he had some very interesting, he went into all the mechanisms sort of how NR could possibly benefit aging, and discussed a lot of what you had talked about, basically by, reducing some of the DNA damage that's occurring, whether it's due to environmental exposures or sunlight. Regarding the CD38, I can't say I'm entirely up to date. Is it an inflammatory regulator, or could you, go into maybe the mechanisms of why we would want to inhibit CD38 in the first place, and then how apigenin is inhibiting that?
Yeah, sure. So there was a paper, I think it was published in 2017, that wanted to figure out, why did it seem that NAD levels declined with age? And one of the enzymes that was correlated with this decline in NAD was CD38. So what they did is they genetically modified these mice so that they couldn't express CD38. They knocked out that gene. And they noted that these mice, their NAD levels were completely fine throughout their life. Now, those mice, they did have other health issues when you blocked out CD38. So it doesn't look, we certainly don't want to completely block out CD38. But what's possibly interesting is that if we stop CD38 from increasing as we age, maybe we can keep our NAD levels at a relatively constant, so-called youthful level. And CD38, it seems to increase as we age, possibly because of this idea of immunosenescence. So, when we age, we build up these old immune cells, if you like, and they're releasing all sorts of factors that we possibly don't want. And one of those factors might be CD38. So if we stop that increase, maybe we can, help our metabolism weather those storms, as Dr. Charles Brenner talks about, and possibly extend health span and lifespan, as this new mice study showed. Again, we're at the infancy of this, and one of the trials that I would love to be able to run is looking at human muscle biopsies. And if we could take older adults, say 60 over the age of 65, and if we gave half of them apigenin or another type of CD38 inhibitor versus placebo, to see what actually happens to the muscle NAD and what happens to muscle performance. I think that would be a really interesting study, because I think this paper was published in 2020, where they gave nicotinamide riboside to older adults to see what would actually happen to the NAD levels in muscle. And essentially, NAD itself didn't change. There was a suggestion that maybe that there was a difference in the overall NAD metabolome. So maybe there were benefits, but the actual NAD levels didn't change. But maybe, and again, this is a maybe, CD38 inhibitors, they might be able to actually increase NAD levels and improve muscle performance. It would be an interesting thing to try.
It would. And really what I think most people are interested in, and this is something that I discussed with Dr. Brenner as well. We were talking a bit about, NAD, and then we were also talking about sort of these biological aging tests that can be done, that are kind of all out there, the consumer biological tests. And he goes, and we talked about, if you're going to do a study on an intervention or whatever, yeah, say NAD levels are important, but what's really important is muscle performance. So if you were going to run a trial such as the one that you were sort of describing, yeah, we want to see NAD levels and how the metabolome is affected, but we want to see markers of muscle performance. Like, are your levels of, say, either strength or mitochondrial function, whatever, are those improving with age? Like, that's really what people care about. And I was discussing again with Dr. Brenner, like, yeah, if your biological clock test that I sent my blood sample in for tells me that I've decreased my biological age by 20 years, but I'm not performing like my self 20 years ago, then what does it really matter? It's just a number, and it's just, if we're measuring the methylome or these different clocks that are proposed as a measure of biological age, I think there's some validity to them. But again, performance is really what matters. What sorts of outcomes would you, measure if we're just having a trial like this? What kind of outcomes would you be interested in measuring regarding performance?
So just to cover a couple of the points that you brought up, I couldn't agree more that it's functional outcomes that actually matter. So, if I don't recommend to anyone really to do DNA methylation clocks, because I just don't think that they're helpful. Say if I'm seeing a patient in the clinic, and they're doing a particular intervention and they can see a massive change in their DNA methylation, I don't necessarily care. I just want to know, are you stronger? Are you fitter? Do you have lower rates of heart disease? That's the stuff that actually matters. So yeah, I couldn't agree more with what you've just said, that the utility of using these DNA methylation clocks for the general consumer, I'm not convinced there is much. So when it comes to clinical trials, so taking my Rapamycin trial, for example, the primary outcome that we're using is the 30-second chair stand test. So how many times can you stand up and sit back down in 30 seconds? That's interesting because in older adults, that's a key marker to their muscle performance. Because what we're trying to do is reduce the need for rest homes and private hospitals. If we can make sure that these patients, when they're older, they can still do the activities that they want to do. They can shower themselves, they can get out of a chair, they can go for walks with family and friends. That is what matters, not what the DNA methylation clock will tell you. So
absolutely, yeah.
Yeah. So when it comes, so if I was to, so I find CD38 interesting. So as well. So if I was designing a trial like this, yeah, I would do, I would want to measure functional outcomes. But since we're at the infancy of would CD38 inhibitors actually work, it is important to still do those initial studies looking at how might this molecule be working. So that's why I'd want to do the muscle biopsies to look at NAD as well. So yes, would be measuring the functional outcomes as well, such as their bench press tests, or how far can they walk in 6 minutes, things like that. That would be interesting, but I would want to measure the muscle biopsies as well to see what the NAD levels are actually doing and whether we can see that the mitochondria are so-called healthier.
Yeah, I think that would be important and data that everyone would want to see as well. Because yes, while functional outcomes are the most important thing, it's also, we want to see what's going on inside the cells and whether the molecule is actually having the effect that it's proposed to have. But yeah, grip strength could also be sort of something interesting to measure, as could something like, maybe in older individuals, a test harder to run, but something like VO2 max, or maximal oxygen consumption, because, a lot of times I think there's like a threshold for frailty. That's like if someone's below 15 milliliters per kilogram of oxygen, that's kind of correlated with frailty. But, the possibilities are endless in terms of what you could measure, I'm sure.
Just on that point, because I think in terms of measuring VO2 mass and functional outcomes, that actually segues quite nicely into a molecule that I used to take, but I don't anymore, and that's Metformin. So Metformin was often hyped as a molecule that could hopefully significantly extend both health span and lifespan, because that's what we could see in the worm data, so from C. elegans, and also from certain inbred strains of mice. So, and we could also see with observational data in humans that it looked like people that were taking metformin actually had lower rates of heart disease compared to people that weren't taking metformin. So that was the initial hype, and that was the reason why I was taking metformin. But now there's sort of 3 key papers that have come out that have convinced me not to take metformin if you're not either diabetic or pre-diabetic. So the first one is, again, from the interventions testing program. So they gave metformin to mice to see what it would do to health span and lifespan. And essentially there was no benefit seen whatsoever. So that's important, that in my view, yes, some of the preclinical data is exciting, but the interventions testing program is the creme de la creme for health span and lifespan. So overall, there was no benefit. So
this would be in health, and this would be in like healthy non-diabetic mice, correct?
That's right. That's right. So that's the first paper. The second paper was published in 2019, and this was looking at a functional outcome. So it was looking at muscle performance and specifically VO2 max, and it was looking at whether metformin would actually block the positive effects of exercise. So what this paper did is for 13 weeks, they exercised both groups, but one group was taking placebo, the other group was taking metformin. And they could see that the benefits of exercise, when you took metformin, it was essentially cut in half. So the increases in VO2 max were only half compared to placebo. So that's a crucial point, that and there's a good mechanism for why we could see that effect. So we've got good data showing that metformin does block and does prevent some of the positive effects of exercise. So metformin doesn't seem to give much benefit, and it's associated with harm. The third paper that came out just recently, I think it was this year, came from the Diabetes Prevention Program. So this was a program that started in the late 1990s, and what it did is for one select population, they were high risk, so they didn't yet have diabetes. They weren't pre-diabetic either. They were just overweight or had high levels of resting blood sugar levels. So they gave half of them metformin and the other half placebo, and they followed them up for a long period of time. So, and there was no benefit seen in cardiovascular disease, in cancer rates, in lifespan or other health span metrics. So it looks like we've now got mice data showing that there's no benefit. We've now got human data showing that there's no benefit in non-diabetic patients, and it's associated with harm in terms of the blocking the positive effects of exercise. So yeah, I don't take metformin anymore because of those 3 trials.
Yeah, and then you mentioned, could you briefly describe how metformin in, say, diabetic people work, and sort of like the mechanism? And then you did discuss in the paper in which it blunted the effects on VO2 max of exercise. Can we get into the mechanism of why metformin might be blunting those beneficial effects?
Yeah, sure. So I think it's quite crucial to mention that in pre-diabetic patients, metformin certainly has a role. And in my type 2 diabetic patients, metformin is the first line medication that I'll be prescribing. So metformin certainly has a massive role to play in human health. But in terms of non-diabetic patients, that's where it doesn't seem to give any benefits, and it's associated with harm in terms of those exercise effects. So metformin, it's an activator of another nutrient sensing enzyme called AMPK. And AMPK, it's got a lot of effects within the body, specifically around the mitochondria as well. I don't necessarily think we've got a great the mechanisms of metformin. It's a so-called dirty drug. It's got a lot of different effects in the body. So it's quite difficult to pinpoint what exactly metformin is doing in terms of both its benefits and its potential harm with the exercise. But AMPK, it is associated with muscle performance. So it looks like if you're always overactivating AMPK, possibly that's the reason as to why we see this blunting effect with exercise. And it's a similar thing with rapamycin. So like I said, mTOR, bodybuilders want to switch mTOR on. So if you're using rapamycin and you're always switching mTOR off, there's the potential that you might blunt the positive effects of exercise as well. So yeah, that it's not clear cut, essentially, is what I'm trying to get at with both metformin and rapamycin. And it's why with rapamycin, in my clinical trial, it's only going to be used once a week on the days that people aren't exercising. And it's because of these, it's because of this blunting effect of exercise that we've seen with metformin that we don't want to have happen with rapamycin.
Yeah, now that you mention it, I have actually heard Dr. Peter Tia mention he was also an individual who used to use metformin and talked about how he had used it. Again, he described the mechanisms in terms of it being the quote dirty drug that you just talked about. He's like, it works, but we don't know how.
Yeah.
It works in some way, but we don't really know how. And he actually also talks about he recently stopped taking it as well because he was just seeing these massive impairments in his exercise capacity with it. He was doing some lactate measurements and things like that. I don't know all the details, but he mentioned how he stopped taking it for that reason alone. He just said he could not exercise at the level that he used to when he was taking it. So pretty fascinating. And I think that it goes to paint a picture on how something that's beneficial in a clinical population might not necessarily translate to humans. You keep mentioning your clinical trial, and I would actually love to maybe briefly just discuss that. I know there are a couple more supplements that I'd like to discuss with you that you have stopped taking, but maybe we pause before we do that and just discuss this clinical trial in rapamycin that you're going to run soon.
Yeah, so with rapamycin, one of the reasons why I'm so interested in it is because of the lifespan extension that was seen from the interventions testing program. And they've run these experiments multiple times. So again, each experiment they run in 3 separate labs to see what its benefits are. And over again, whenever they test rapamycin, it extends both male and female lifespan. So that's quite interesting. And I think there's a really crucial mechanism that we've already talked about with how it might improve muscle performance in both mice and in humans. And that's around making sure that mTOR is switched off and on correctly as we age. So I wanted to trial this and see, do we see muscle performance benefits? And I wanted to choose a functional outcome because, like we've gone through, that is what actually matters. It's not what some blood test is telling you. It's what, it's how you're feeling and how strong you are, et cetera, et cetera. So we chose the functional outcome of the 30-second chair stand test. So this trial, it's a phase 2 study. And what we wanted to first figure out is what happens to muscle performance when you combine exercise with rapamycin. So both groups will be exercising, but one group will be taking rapamycin once a week and the other group will be taking placebo. And we wanted to start with a relatively small trial, so only 20 participants in each group, because we need to first make sure that this molecule is safe to give in older adults, and that it's not going to cause negative impacts on exercise. We don't think it will. We think it will actually improve muscle performance, but we need to first show that in published data. There's a whole bunch of other secondary outcomes that we're looking at as well, but this paper is primarily to look at functional outcomes with muscle performance. And once we've got that data, if we can first show that it's safe and that there's a trend towards improvement, so that's quite crucial here. This trial, it's not powered to see is there a true superiority. All we're trying to first make sure about is this safe and is there a trend towards improvement? Once, if that proves to be correct, then we've got the means or the rationale to go towards a much larger superiority study. Again, if that much larger superiority study is successful, as in it does show a positive improvement, then I think we'd be ready to actually apply for FDA approval to get rapamycin used in older adults. So that's kind of the path that I can see to actually getting this molecule into the general human population to improve their muscle performance. So I'm quite excited about what we're doing. So again, I can see that path to reducing the need for rest homes and private hospitals if rapamycin works in the way we think it will.
Absolutely. That's very exciting. Is there going to be just a rapamycin control group? So say a group that's taking rapamycin but not exercising, or was there like a rationale maybe behind not doing that?
Yeah, great question. So there's a separate trial that I'm not involved in called the Pearl study. So what they're doing is taking older adults and giving half of them placebo and the other half rapamycin, and they're not exercising them. So that will answer the question of what happens to muscle mass and fat mass. And I think they're doing a couple of functional outcomes as well. But that will answer for us what happens if you just give older adults rapamycin. And so it's a very important study that they're doing. And equally, I'd argue that my study is as important, because we need to know what happens when you exercise, because exercise is a fantastic way to slow down muscle decline as we age. So to me, it makes sense that if we're going to use an intervention to help muscle performance in older adults, we should be combining it with exercise. So this trial that I've designed will answer that question as to whether we will get even greater muscle performance benefits compared to just exercise alone.
I think that's very important, because we're never going to not, or I guess one shouldn't never not prescribe exercise and just say, oh, you can take rapamycin when you age, it's going to, help your muscle mass. It's like, you always have to prescribe exercise. So what's really interesting to me now is that we know that exercise is good, and there's really, do we really even need more research on that? But now what can we add to the stack to exercise to help, especially older individuals who might have a lack of a response to exercise, or anabolic resistance in muscle or something like that. So I think that's a very interesting clinical trial, and it's exciting to hear that you're doing that. Is there somewhere that people can find information on that trial, or anywhere where you've talked about it, say on your YouTube channel or whatever, if I could add a link to the show notes or something like that?
Yeah, absolutely. So the trial's recently been, so we're never doing a human clinical study. It's important for IRB or ethics approval to register your study. So by registering your study, essentially you're saying what you are going to do and what your primary outcome is going to be and your secondary outcomes. So I can share a link to that, and within that registration, you can see the full study design, including another link to the rationale. So it's a 28-page document that with references and everything, explaining how we're doing this trial and why we're doing this trial. So I can link that. But under each video that I've done for the past, I think 6 months, there's a link to the fundraiser to help fund this trial. So yeah.
Great. And so are you still accepting funds to fund the clinical trial?
Yes. Yes.
Great. Yeah. So I think that's good to know, because if people want to donate to that and help kind of fund this research, I think many people will be interested in doing that.
Yeah. Yeah. No, absolutely. We're always looking for extra funds. And like I said, I'm focusing on rapamycin because I find it an extremely compelling molecule. But there's a whole host of other trials that I'd love to do. And, we've talked about CD38, for example. I'd love to do a trial on that. Yes. So there's many other molecules that I'd love to trial and see if that does help with human health span and lifespan.
Yeah. You're running your own interventions testing program. And so, there are a couple more supplements that you've mentioned that you stopped taking. So I would like to maybe discuss those just, very quickly. So I know that Resveratrol and then NMN are two that you've mentioned. So can you talk about why you maybe used to take both of those, and then why you no longer take them? I would love to hear.
Yeah, absolutely. I think let's just, there's a couple of other molecules that I am taking that I think would be useful just to bring up on this, and then we can talk.
Yeah, we can list those before.
The other molecules that I'm taking that I think are interesting is fisetin and quercetin. So these are molecules that are so-called senolytics. So as we age, it seems that we build up these old senescent cells that are no longer dividing, but they're releasing all sorts of factors within our body that seem to damage the surrounding tissues. And so it looks like if we can remove some of these senescent cells, maybe we will see health span benefits. So there's actually a number of trials going on from the Mayo Clinic, led by Dr. James Kirkland, looking at fisetin specifically to see whether it will improve aspects of health. So it looks like by taking these molecules, there's the so-called hit and run protocol, where for a certain period of time in the month, so I take fisetin 5 days in a row each month. So it's just at the beginning of the month to help clear away these senescent cells. But then for the rest of the time, you just let the body do what it needs to do. So I think, again, that the human data is coming, the mice data, but I take this molecule because the mice data is quite compelling. So that's just another area of research that I'm interested in. But yeah, moving on to the supplements that I used to take but no longer take. Yeah, so we've talked about metformin. I also used to take resveratrol, and this comes back to, you know, one of the reasons as to why I started my YouTube channel in the first place was because of listening to Dr. David Sinclair on the Joe Rogan podcast, and the way that he was describing describing resveratrol was that it was an amazing molecule with very good preclinical data, and the human data was looking very positive, and that it was just a matter of time until virtually everyone would be taking resveratrol. So I went down that rabbit hole, and I took resveratrol for about a year, and over that time I came into contact with other researchers such as, you know, Dr. Matt Kaberlein, Dr. Charles Brenner, Dr. Brian Kennedy, and I had a deeper dive into the actual history around the resveratrol research, and it's quite a I suppose the word is a scandalous story. I don't really know another way to
that might be a good word to describe it. It's a lot deeper than I even knew, and you know, that's why I wanted to talk to, you know, Dr. Brenner about it. He was posting these Twitter threads, and I'm like, wow, this stuff goes really deep.
Yeah. So essentially, the original research centered around these enzymes called sirtuins. And this is the research that Dr. Matt Kaberlein was heavily involved in, because it looked like if you overexpressed the SIR2 gene in yeast, that it looked like you could see these lifespan benefits. So then they wanted to see if you overexpressed, if you used specific molecules to activate SIR2, would that give these lifespan benefits as well? And from the Dr. David and from the Sinclair lab, it seemed that yes, that if you used specific molecules, and in this case resveratrol, that you could activate the SIR2 gene, and you could see these lifespan extensions seen in yeast. So then they trialed them in mice, and this paper, I think, was published in 2006. And what it did is it took otherwise healthy mice, and it compared them to mice that were on a highly toxic, high-fat diet. And they could see that the lifespan of the healthy mice that was constant, as we would expect, but the toxic diet, it significantly reduced the lifespan of those mice. So then what they did is gave that toxic diet to these mice and paired it with paired it with resveratrol, and they could see that toxic diet in combination with resveratrol, those mice could actually lead. Their lifespan was exactly the same compared to those otherwise healthy mice. So that generated a lot of excitement, and Dr. David Sinclair then sold his intellectual property to GSK, so a drug company, for $720 million. And it all seemed rosy, that, you know, that there was very good research showing that you could activate sirtuins and that we'd be getting all of these benefits, and it seemed wonderful. Then in 2009 and 2010, multiple separate labs, they tested this resveratrol hypothesis, and it seems that actually you can't use resveratrol to activate sirtuins. It doesn't work. And the original experiments, they were flawed because of a fluorescent dye, that if you combine the fluorescent dye with resveratrol, then yes, you could see that that you can activate the sirtuins. But you know, we don't have fluorescent dye in our bodies, so there's no mechanism for how resveratrol can activate sirtuins. And when they went back and gave so this is what Dr. Matt Kaberlein did, I think. I'll just switch camera. Sorry, just edit this bit out.
No problem.
Sorry, sometimes my camera overheats, so I'll just switch back to my webcam.
Sure.
Sorry. There we go. Sorry about that.
Yeah, no problem.
Yeah, so when Dr. Matt Kaberlein and Dr. Brian Kennedy, they redid the experiments with resveratrol to see whether you could get these benefits in yeast, there was no benefit seen. So no one could replicate the original results from the Dr. David Sinclair lab. So you can't reproduce it. the actual mechanism for how resveratrol is supposedly works in terms of activating sirtuins is flawed. And when the interventions testing program trialed resveratrol in consultation with Dr. David Sinclair, so you can see his name actually on that paper, so he was consulted, and they used a very high dose of resveratrol, there was no benefit seen whatsoever. And because of all of this controversy, then then Dr. David Sinclair had to try and his lab had to try and salvage the situation. So in 2013, they published a paper that in their mind shows conclusively that resveratrol does activate sirtuins, but it's using specific peptides that don't correlate with the original experiments that he did, and doesn't really correlate with the overall human body. So yes, you in specific circumstances in cells in a petri dish, you can make resveratrol activate sirtuins, but it doesn't correlate with his original experiments, and it doesn't correlate with how the human body actually works in a whole organism. So it's when I was looking through all of this, I couldn't quite believe it. So I reached out to David Sinclair in early 2020 and early 2021. And then I made a video explaining all of this research. And I didn't mention Dr. David Sinclair's name whatsoever. I just wanted to present the papers and present the history of it. And again, I sent that to David Sinclair to get his response. Unfortunately, on Twitter, his response was 2 emojis. One was horse and the other one was the poo emoji. And then I made another video about 2 months ago where I did mention that it was the David Sinclair lab, because I don't think people realize that, he made a significant amount of money from this initial research that other researchers have now shown is, flawed. So it's interesting. And I think people need to know about this controversy before taking the molecule, because it's not that it's not fine, but if there was no benefit, but there was no harm, then I wouldn't necessarily care that much. People can do whatever they want to do with their money. The issue is that resveratrol, there's very good data showing that it blunts the positive effects of exercise, like what metformin does as well. So by people taking resveratrol, if they're exercising, they're actually worsening their health. So I get quite passionate about this because, at the end of the day, we just want people to be as healthy as they can. And if something is interfering with the trifecta of diet, exercise, and sleep, that's not great.
Yeah, I mean, I can certainly even see, as you're talking about the story, like your passion and like the 2 videos that you made are very informative, and you list in them a lot of sort of the issues with the studies that have been done, but also just the issues with resveratrol as a molecule in terms of like its poor absorption and why sort of the studies mechanistically would kind of be flawed. And like you mentioned, I think that sure, we can really say that many maybe making overblown claims about resveratrol are sort of benign, but I would agree with you in that they really aren't. I mean, for one, just people are going to invest in products containing resveratrol. I mean, this resveratrol has become like an industry in the past decade. I mean, the red wine, which is completely ridiculous anyway, but just sort of, it's all now correlated with red wine. The benefits of drinking red wine are for resveratrol. You go to a supplement section in a Whole Foods or any supplement store, I mean, there are resveratrol only supplements. And then, people, again, whether or not resveratrol is actually going to provide harm, so they're, wasting your money. So that's, harmful in and of itself. But also, and something that Dr. Brenner has mentioned on Twitter, the billions and billions of dollars in research money that have been spent that were based on this initial hypothesis from the Sinclair lab that resveratrol activates SIR2, and just the amount of scientists and taxpayer funding and things that have gone to looking into this molecule that, could have been avoided if, none of this had initially come up. So it's not, without consequence that sort of these claims were being made. So I do think that it's important that people know, and I really appreciate that individuals like yourself and Dr. Sinclair and even Dr. Matt Kaberlin are talking about this, because I think it's very important. And unfortunately, it took this long for the discussion to kind of get started.
Yeah, and like you say, it is unfortunate that it's gone this far, and all of that research that has been done that could have, you know, I just think how great would it have been if some of that money went towards rapamycin.
Right,
You know,
right.
the state that we would be in now. So you're absolutely right that a lot of money has arguably been wasted on this field. Yeah, it's unfortunate, but at least people are talking about it now, and I think people, you know, such as yourself and a lot of other researchers now, that they know the story, they know the pitfalls, and hopefully we can kind of move on to other more promising ideas again, such as rapamycin.
Yeah, I hope so too. And again, you know, clinical trials like the one you're running and others will definitely help with that. So, you know, I think one thing I just wanted to maybe end with for like your supplements and talking about all that, I think a couple practical things for listeners to maybe just know are like the form in which you're taking your supplements. So, you know, how are you trying to get most of it from food? I mean, I know you know, food contains some of what you're taking, but is it a majority just in pill form or maybe a drop type of form? You know, how are you actually getting in your supplements?
Yeah, so I think that's a really important point that so you can't beat a great diet, right? So most of the time, if you're eating whole foods, a wide and varied diet, most of the time you don't need to supplement. So, you know, for example, I take a very small dose of zinc and I take a very small dose of magnesium, and that's because generally speaking, it can be quite difficult to reach those recommended daily intakes of those molecules without a small supplement. So, but again, most of the time, specifically with things like, you know, vitamin C, you can get all of the vitamin C that you need from your diet. So you don't need to supplement with vitamin C. But the other supplements that I'm taking, it's in pill form. So, but it's the vast, and sorry, I can't emphasize this enough. The vast majority of benefit is from that trifecta: diet, exercise, and sleep. Everything else that we're talking about with supplements, the preclinical work is interesting, and there is some human data coming through, and we talked about that at the beginning of the podcast. But you can't ever replace a great diet, exercise, and sleep.
No, I appreciate you bringing that up, and I think a lot of my listeners will sort of hold that same opinion. And it's like I think that people, you know, lose trust in individuals, and there are very few of them out there, but say like, oh, they're not exercising or not eating a healthy diet, and they're just sort of recommending, you know, just supplement yourself out of all that stuff. I don't think it can be done. So,
No.
you know, it's good to hear that you have that perspective, because I love how you're sort of just very evidence-based in terms of the supplements you take. And, you know, you're taking a huge stack of supplements, which is great, but you're also like, these foundations of the low-hanging fruit need to be taken care of first before one kind of looks into what supplement should I add to my regimen to improve health span.
Yeah, and it's like we've talked about with, you know, resveratrol and metformin, taking those molecules was harming me. So, and it's possible that it's possible that Fisetin, taking that 5 times a month, maybe that's harmful as well. So it's not without its risks. And I think people need to be aware of that if you simply just want to be healthy, diet, exercise, and sleep, and then waiting for high quality data to come through. And I think that there's enough interest in this field to get these trials funded so that they can actually be done. Yeah.
And people should test for themselves. I mean, again, another thing I appreciate about your supplement regimen is that it is so evidence-based, and like, you know, you're describing how you think about not only what supplements you're taking, but when you're taking them. So, you know, this was particularly interesting when you were talking about the antioxidants that you're taking, because there is good data to support that. If you take, say, antioxidants in the context of exercise, it can blunt many of the beneficial adaptations. So, okay, I'm going to take my antioxidant on a non-training day, or, you know, maybe think about taking certain supplements in the morning or the evening, because I think nutrient timing is a super important and very interesting field, just as like meal timing is. You know, it's not only what you eat, but it's also when you eat. So same goes with supplements. It's not only when you take them, but, you know, what you're taking, but also when you take them. So I think that people should also, you know, look into what's the optimal regimen for the supplement, and not just wake up every morning, take my stack of 20 pills and call it a day. I think more thought needs to go into it for sure.
Yeah. And on that, sorry, just last point about supplements, and I don't want to bag on supplements too much, but you know, you've got highly experienced preclinical researchers such as, and again, let's just take Dr. Matt Kaberlein, for example. So he was one of the original researchers around sirtuins, and he's running the dog aging project. He's well versed in all the literature. The two supplements that he takes that I'm aware of is vitamin D and rapamycin, and that's it. So, and if you look at someone like Dr. Morgan Levine, who's one of the leading researchers at Altos Labs, looking at epigenetics and whether that, whether we can do anything about that for aging, she takes no supplements, and she's well versed in this field. So, yeah, supplements are at this stage a very small part of the overall picture, and that picture is diet, exercise, and sleep.
Absolutely, and it's just important to reiterate that, like, a lot of what we talk about supplements is sort of unknown. A lot of it is sort of theoretical at this point, but a lot, I think there's sort of maybe a high potential benefit and a very low potential downside to a lot of them, other than maybe you waste your money if something doesn't work. And so I think that that's kind of the good thing about supplements. There's some freedom to experiment with maybe, putting a little dent in your wallet and perhaps nothing else, rather no serious kind of clinical side effects that are likely to occur from a lot of these things.
Yeah. And I suppose in saying that, if you had to pick a few supplements that have good human data with a very low risk profile, we've got good data now that vitamin D is great for humans, and because we're sitting indoors a lot of the time, we're not getting enough vitamin D. So taking between 2,000 and 4,000 units of vitamin D, there are benefits that we can see both on the immune system, and this data was published in the British Medical Journal, where it reduced the incidence of coughs and colds. And just this year, we've got data showing a 22% reduction in autoimmune diseases by taking vitamin D. So, and with these long-term studies, there's no downside to taking vitamin D. Again, just at that small dose. So I'm certainly not advocating for mega dosing of vitamin D, but between 2,000 and 4,000 units, that seems to be great. It's the same thing with omega-3. There doesn't seem to be any downside aside, once you've made sure that the capsule that you're taking is actually pure, there doesn't seem to be any downside for taking 1 gram of omega-3. So if I was going to say with my parents, if I said to them, there are 2 supplements to take, I'd probably say vitamin D and omega-3. And I think that's a reasonable place to start.
No, I definitely think so. And if people are, wanting to get started on supplements, I think they could start there. But certainly, your stack and everything you've mentioned today are also available that I think, are interesting to look into. I have one question about maybe a final supplement that may not even be considered a supplement. And I'm not sure how much you know about this or are kind of into the research here, but do you have any thoughts on exogenous ketones? So this is kind of an area, I have been taking exogenous ketones for a while now, just experimenting with different brands from different companies. And so, there's all hype around the keto diet and fasting in particular. Both of those interventions can increase ketones. There's some literature in animal models that ketogenic diet can maybe increase health span. Are you aware of anything, or do you have any thoughts on exogenous ketones, or perhaps you're just not at all interested?
No, I'm interested. And so I think let's start with the keto diet, because this was, again, another diet that generated a lot of hype, where it was thought that if we could significantly reduce our insulin levels, that there would be significant lifespan and health span benefits. So let's take the example of one paper comes to mind. So this was in mice, and it looked at the keto diet, and it compared it to just a regular diet. And what they could see is that the ketogenic diet, there were significant benefits. But when you have a look at how they actually ran that paper, the control diet was high in sugar, but you could see that the ketogenic diet was calorie restricted. So are the benefits from the keto diet, or is it because the control diet was high in sugar and was unrestricted calories, whereas the ketogenic diet was reduced calories? So the devil's in the detail when it comes to hype like this. And we've got very good human data now looking at, low carb diets, ketogenic diets for weight loss. Essentially, there's no advantage. I'm about to publish a video on this. When it comes to weight loss diets, what's actually important is how many calories you're eating. So, some people use intermittent fasting to reduce their calorie intake, but that's it. It's simply lowering your calories. It's nothing to do with the diet per se. So and Dr. Matt Kaeberlein, towards the end of 2020, published a fantastic review article. I think it's titled Anti-Aging Diets, Hype or Fictional Hype or something like that, where he goes through all of the preclinical and clinical work. And essentially there's definitely not one clear winner about a perfect diet. The Mediterranean diet may have positive effects on cardiovascular disease, but even then it can be a little bit shaky. And one of the things that Dr. Matt Kaeberlein talks about in that paper is, does everything just come back to how we influence mTOR, which we've talked about in this podcast already? So yeah, I don't practice the keto diet. I do not practice the low carb diet either. I think, yeah, the initial hype around all of that, it's from the data that I've looked at and from the researchers that I've talked to, it is just that it's hype. So when it comes to exogenous ketones, so I've not specifically looked at the research around that, and that's primarily because I'm not that excited about the idea of boosting ketones in the body.
Yeah, no, I mean, that makes total sense. But I think, one of the things that we need to differentiate between the two, and I'm only saying this because I've done a decent amount of reading and sort of writing even about exogenous ketones, is that sort of the theory behind why they may promote health span and lifespan is that beta hydroxybutyrate, being one of the ketone bodies that our body produces when we're in a ketogenic state, has actually these downstream signaling cascades that may mimic some of the effects of, say, fasting and calorie restriction, independent of, say, diet. So it's almost as if it's a longevity supplement. And there's a good paper by Eric Verdin and John Newman that kind of discusses BHB as a signaling metabolite. So I think the theory behind that is that, if we can, say, activate or inhibit certain pathways, similar to what certain supplements might do, that ketones may be able to do that. But I do agree with you that there is some hype surrounding fasting, ketogenic diets, at least for weight loss. But I think the exogenous ketone, what interests me at least about them, is that they're sort of separate from weight loss, and almost in this viewing them as like a longevity supplement, because they're definitely not a weight loss supplement. And any of the companies marketing them will say, they're not for weight loss, they're for energy, whatever. Again, that research still needs to be done. Not a lot of evidence for exogenous ketones either, but at least a little interesting preliminary data on them. So I was just curious to get your thoughts.
Yeah, no, I haven't specifically looked into exogenous ketones, again, because my excitement's not necessarily there. So you'd be more versed in the data than I am. But if it's talking about downstream signals, again, to take the Dr. Matt Kaeberlein spin on it, is it all just to do with mTOR? So I don't know, but we've kind of brought up fasting, and I think this is quite another so-called longevity strategy that was hyped. And the reason it was hyped is that in mice, when the mice were fasted for 16 hours and they could only eat within an 8-hour window, if you compared that, and this was calorie matched. So what I mean by that is, one group was doing this time restricted feeding or intermittent fasting, and the other group was eating whenever they wanted, but both groups were eating the same amount of calories.
Right.
The intermittent fasting group, or time restricted feeding group, they seemed to have these health span benefits, as in lower rates of heart disease and cancer, and also longer lives. So that generated a lot of excitement that maybe humans could get that as well, that if we ate within an 8-hour window in the day, that we could get all of these benefits as well. Essentially, there's no evidence that in humans that happens. And actually, when you do the trials, so let's take weight loss, for example. if you calorie match the groups, as in both groups are eating the same amount of calories, there's no difference in weight loss when it comes to time restricted feeding compared to eating whenever you want. There's also no difference when it comes to blood sugar levels. So if people were saying, oh, well, you know, time restricted feeding helps with your insulin levels, there's no evidence that that actually happens. There's no evidence that it improves heart disease in humans. There's no evidence that it helps with cancer rates. And these are, you know, these are important findings that I think people should be aware about, that, you know, time restricted feeding, it's not a new idea. We've got good data on it now, and it doesn't seem to improve health. The caveat to that is that it seems that if you get most of your calories in the morning, that actually seems to be beneficial. So, you know, and sorry to bring him up again, but, you know, Dr. David Sinclair will talk about his time restricted feeding, where he'll get most of his calories at night. Again, there's no evidence, A, that will be beneficial, but B, that's probably harmful. We've got good data showing that as well, that you don't really want to be getting most of your calories in the evening. You want to be getting most of your calories in the morning. So
no, absolutely.
Important.
I've heard him discuss that too in his protocol, and kind of seen a decent amount of criticism on that, at least from like the so-called fasting experts, because it's in contrast to the evidence that early time restricted feeding is better if you're going to do it, versus, you know, slamming all your calories between, you know, 7 and 10 p.m. right before you go to bed. It doesn't seem the ideal way to do it.
and people can measure this themselves as well. You know, if you've got one of the heart rate monitors, you can measure your heart rate, and you can compare if you have a small dinner compared to if you have a massive dinner, and see what that does to your heart rate overnight. And if you have a massive dinner, your body's working hard to digest all of that food. And you can see, you know, that your heart rate's massively increased, which is not really what, and that's just one metric where it's not good for you. So yeah, it's you need, the advice that I just give to people is that, you know, clinical doctors such as myself, we get a lot of I see it online, also in the comment sections of particularly other channels. We get mocked a lot about how, you know, we don't prescribe time restricted feeding. We don't do all of these, you know, wonderful interventions such as the ketogenic diet, and we don't because the evidence doesn't back it up. And if anything, the evidence is contrary to those to those strategies. So I suppose my journey so far of looking into this longevity and health span research over the past 2.5 years, I've actually become really grateful for the field that I'm in, because, you know, the guidelines that I'm following in my clinical practice, they're robust. They've got good data supporting them, and the other weird and wonderful things that come out, they don't, and that's why we don't prescribe them.
Yeah, and you're seeing it firsthand. A lot of you know, a lot of people who criticize the whatever, you know, traditional medicine is prescribing, they're not seeing whether or not the interventions are affecting patient quality of life or how they're affecting these certain outcomes. But just to, you know, go back quickly to the diets, I completely agree with you in that calorie restriction, intermittent fasting, time restricted feeding, ketogenic diet, they can all work, but they're ways to reduce calories. Many people find that the way to reduce daily caloric intake is to time restricted feed. Yes, it makes it easier for a lot of people. If I can only eat in a 6-hour window, I'm probably going to eat less than I would if I were eating a 12-hour window. Same with the ketogenic diet. They find it more satiating. They're less hungry all the time. They're going to eat less. And that's kind of where the benefits come. I know there's a whole camp who is saying, you know, there's this carbohydrate insulin model of obesity where if you reduce insulin, you're going to, you know, improve metabolic health. And that's why the ketogenic diet is better. But really, I think you really just touched upon really an interesting, a great point, that it's, if you restrict calories, restrict energy intake, and are in a deficit, you will lose weight and you'll improve certain markers of metabolic health. How you achieve that is totally up to you and is going to be different for everyone. Fasting and intermittent fasting and time restricted feeding seem to be particularly effective though. So I think that's kind of why many people do take to those interventions.
Yeah, and I think let's talk about the the satiating effects of the ketogenic diet versus, you know, a carbohydrate diet. So
yeah, sure.
So I'm not, I certainly don't advocate necessarily that one diet is better than the other, but what I will say in defense of carbohydrates. So I'm talking about so-called complex carbohydrates, as in whole foods. If you have a look at the energy that's actually within, say, 10 grams of fat versus 10 grams of carbohydrates, carbohydrates have got almost half the amount of energy. So effectively what that means is you can eat twice as many carbohydrates for the same energy that you'd get from half of the fats. So in that way, carbohydrates are satiating because your stomach is fuller, and you've got you've got the same amount of energy. So that's
right.
sort of
volume wise.
Volume-wise, yes.
Fuller,
So that's sort of point number one in defense of carbohydrates. The second thing that I would say is that generally, if you're eating whole foods with carbohydrates, so one of the dietary things in clinical medicine is we do promote eating whole grains. And if you talk to someone who's doing the ketogenic diet or is a firm believer of the carbohydrate insulin model of obesity, they will say, whole grains are the worst. You can't possibly do that. But again, you get a huge amount of fiber from that, and that fiber then through the mechanisms with your gut bacteria, they send signals to your body to say, I'm actually full. And you can eat, again, you can eat twice as much whole grains compared to fat for the same amount of energy. So this is the thing. I think if people are too much in one camp compared to another, I think they lose sight of the overall picture. The overall picture is for weight loss is that we want to reduce calorie intake, and finding a diet that works for you, that makes you feel full. That's actually what matters. Some people find it with the ketogenic diet, and that's great. Some people find it with eating lots of, fruit and whole grains and vegetables, and that's, to be honest, probably better.
Yeah, and it's one of the things that I really despise about when talking about dietary practices and getting into this dogma, because there is there's accepted thing that, oh yeah, it's a high fat, high protein diet, it's going to keep you fuller for longer. But in my experience, and perhaps maybe yours as well, and in many others' experience, if I'm just eating a lot of fat and protein, I do not feel satiated. If I eat a huge salad with some protein and some good fats on it, I feel much more satiated than I would if I just have a steak with some eggs on the side. That doesn't leave me satisfied at all with my meal. I just want to keep eating more. And I think it's almost that lack of fiber and the lack of the complex carbohydrates. And when I eat a meal containing all of that, say add a huge salad to my steak, it's a lot more gratifying, a lot more satisfying, because I think that volume sort of filling does play a role. So yeah, I mean, you bring up a great point that you just can't accept whatever is said about the keto diet and why this helps people eat less. Yeah, it's going to help some people eat less, but human biology and physiology and neurobiology is so complex that no one diet and no one nutrient is going to act in the same way in one person versus another.
And I think the general public is starting to wake up to that, which I find really encouraging, is that, people like yourself and also on my channel and many other researchers who are well-versed, they talk about this now on ways that people can actually reach them, such as, Twitter, on YouTube, whatever it may be. And the message is getting out there that, these fad diets are not the way to go. And I think people, it's pleasing to see that people are waking up to that, because I think the communication around the science is improving.
Yes, certainly. And obviously for everyone, it just involves a little bit of self-experimentation. So you can't take anything, that you hear, you have to test it out for yourself. And I think that's important. What is your, maybe we'll end on this, and I just kind of like to see, what does your diet look like, during the day? What types of things are you eating? You mentioned you don't really follow a particular diet camp. You're not eating low carb or keto or vegan or whatever, but what is a daily sort of diet plan look like for Dr. Stanfield?
Yeah, so I think it comes back to certain strategies, I suppose, that I use. So, for example, there's some low-hanging fruit. If you're drinking sugar drinks, you're not doing yourself any favors. So, making sure that I'm only drinking water or milk. That's one thing that you can do. with each meal, making sure that I first drink a glass of water, and then between each mouthful, have a sip of water. It's small things like that. When I have a plate of food, say with my dinner, making sure that half of it is vegetables and a quarter of it is the protein that I'm eating, whether it be, a steak or chicken or whatever it may be, or chickpeas, and then the other quarter is some sort of a complex carbohydrate. So that's sort of the general principles about my dinners. In terms of breakfasts, so I often have oats mixed in with berries, such as particularly blueberries. I put in some protein powder into that, put my collagen into that, and then in terms of lunch, that's generally at the clinic. It's usually some sort of a filled roll. It's not, my diet's not particularly special, and I don't think you need a particularly special diet, so long as you're focusing on the fundamentals, which is making sure it's water or milk, making sure you're having a wide and varied diet with fruits, vegetables, whole grains, in my opinion at least, and making sure that you're not having too many sugary foods and cupcakes and things like that. Everything in kind of moderation, making sure you're not having too much fast food. It's nothing. That's the thing. I don't think we need to overcomplicate diets. It's simply a wide and varied diet filled with fiber, low sugar. That's essentially it.
Yeah, well, interestingly, some people will find that statement controversial, which never made sense to me. But
Yeah.
do you do any type of fasting or time restricted feeding? Or it seems like you're doing 3 meals a day generally, but obviously you're doing some sort of time restricted feeding because you're stopping at dinner and eating breakfast. But do you do anything?
Yeah, so I try and get most of my calories in the morning. So there's the saying, it's something like eat breakfast like a king, lunch like a prince, dinner like a pauper, something like that. Yeah. So I roughly follow that. And roughly every 3 to 4 months, I'll do a long fast, so between 5 and 7 days. And so it's a water fast with a multivitamin, and a small potassium pill as well. And that's essentially it. There's nothing particularly nuanced that I do, and it's simply because the evidence doesn't really back it up. Even the prolonged fasting, I do that because of the mice data that we've got around time restricted feeding, because if a mice fasts for 16 hours, I think that correlates to about a human fasting for 4 days, something like that. So that's the reason why I do those prolonged fasts, but there's no human data really showing any benefit. So who knows if it's good or bad.
Yeah, a lot of the, especially the extended fasting data in humans is virtually non-existent. So it's like, yes, maybe promoting autophagy. Some people just like how it feels. And I guess if that's, why it works, then that's totally fine with me, I guess, if it provides you with a quote unquote reset, even though I hate that word, but some people just do it for that, and whatever works for you. I think it's all, all of us are our own N=1 experiment. So it's cool to see what you're doing, and you're definitely practicing kind of what you're preaching. I mean, listening to your YouTube videos, it seems like you're doing exactly what you would prescribe to listeners and prescribe to your patients as well. So Dr. Stanfield, where can listeners find more about your work? I know you have a fantastic YouTube channel that I mentioned before. So if you could maybe plug your YouTube channel, and then is there anywhere else that listeners could find you to find more about your work or see more of your content?
Yeah, so most of it is through my YouTube channel, and that's where I try and do between sort of 6 to 10 minute videos explaining the research around a particular strategy or molecule or new research. So that's a primary place to reach me. But I've also got I'm also relatively active on Twitter, and that's, if there's a new paper that interests me, that I find compelling, I'll mention those papers. So that's where I'll update the research first and then do a video about it second. I've also got a website that I want to build out in the future. I'm actually creating a health checklist, if you like. So one of the things that really strikes me in the YouTube comments when people watch my videos is that they'll be, talking about a particular diet or particular supplement, and that's great and all, but often they're missing the overall point, where if you're over 50 years old, have you discussed with your doctor around the bowel cancer screening? If you're a woman, are you getting your mammograms? Are you getting your cervical smears? Have you had bloods recently to look at your cholesterol levels? Have you had your blood pressure checked recently? What about your prostate? These are things that actually move the needle for both health span and lifespan. Again, prevention is key. So I've created a checklist where if people type in their age and then select their gender, it comes up with a specific checklist about things that I would want my patients to have done to optimize their health. And then once I've done those things, and everything else is such as supplements, we can talk about, but it's those core fundamentals or foundation that I really want people to focus in on. So that's another place to reach me as well.
Awesome. That's great. And yeah, I will include links to all of those places in the show notes where they can find you. And yeah, I encourage people to reach out to you on Twitter, to watch some of your awesome YouTube videos, and maybe, get in the comments and start some discussion on supplements. But Brad, Dr. Stanfield, I appreciate you coming on the podcast today. It was a blast talking with you about all these supplements, and even getting to some things that I hadn't planned to talk about regarding fasting and keto diets and all of that. So it was a fantastic discussion. Always down for round 2 if we have some new data, or perhaps, when your Rapamycin trial, when you begin to collect data, I would love to hear more about that. So thanks again for coming on. I had a great time.
Yeah, me too. It was a lot of fun. Thank you.
Awesome. No problem. Have a good one.
Cool.